Understanding Endometriosis. Webinar recording hosted by the Alliance and Scottish Government.
Thank you so much, everybody, for taking the time and coming along today. I'm Jennifer Stewart. I'm Senior Development Officer for Women's Health at the Health and Social Care Alliance Scotland. And welcome to today's webinar, which is Understanding Endometriosis, which is hosted by ourselves at the Alliance in partnership with the Scottish Government and in support of the Women's Health Plan. We've hosted a number of webinars over the last year or so focused on women's health and the priorities of the Women's Health Plan. And with these kind of sessions, we really hope to empower people, I suppose, with information about their health so that they can really understand their own bodies and their own health needs and get early support should they need it. We have some really great guests joining us today just to explore the topic of endometriosis further. So we have Professor Andrew Horne from Edinburgh University. We've got Vicky Chapman and Julie Burns, who both lead endometriosis peer support groups and have lived experience of the condition themselves. And I'll introduce each in a bit more detail kind of as we go along. But first, our Alliance Director, Irene Oldfather, hoped to lead the session today, but is no longer available to. So she's recorded just a short video just to really set the context for the discussion today and kind of explain from the Alliance perspective why it kind of exploring endometriosis is really important and raising awareness of the condition is really important to kind of furthering women's health equality. So I'm just going to share that.
I'm Irene Oldfather. I'm Director of Strategic Partnerships and Engagement at the Health and Social Care Alliance. I'm sorry that I can't be with you today, but I'm very pleased to introduce this session on endometriosis as part of our work on the Women's Health Plan. Women themselves have told us about the difficulties that they face around diagnosis and treatment for endometriosis. And in this Endometriosis Awareness Month, it's very important that we raise awareness around the condition and that we have open conversations with women themselves around how we treat, support and access information around endometriosis. So can I welcome you to today's session. I look forward to hearing about the important discussions that you'll be having, and I'm very pleased that we have today both clinical expertise with Dr. Andrew Horne and also women themselves with experience of the condition, so that we can have that constructive conversation and actually discuss how we deal with endometriosis in women's everyday lives. So I wish you all the best for a successful session today and thank you for joining us.
Perfect. So thank you, Irene, for that. And I hope that gives you some background on why we're focusing on endometriosis at today's webinar. So I think really we'll just kind of jump right into it. I think that's probably most people settled in on the call. So I'm just going to introduce today's first speaker, Professor Andrew Horne. So Professor Horne is Professor of Gynecology and Reproductive Sciences at the University of Edinburgh and is also the co-director of the EXPPECT Centre for Pelvic Pain and Endometriosis. And Andrew is going to give us a kind of overview really of the condition from his expert clinical perspective so that we can all just really better understand endometriosis and how it might present for different people. There will be time after Andrew's presentation for you to ask questions. So again, if you could pop those in the Q&A box and we'll pick those up. So Andrew, thank you so much for coming along today. Really appreciate you taking the time and I'll just pass over.
So thanks very much, Jen. And it's great to be able to have this opportunity with Vicky and Julie to talk about endometriosis, particularly during March, Endometriosis Awareness Month. So the first thing to say about endometriosis is sadly it's really very common. It's said to affect 190 million people worldwide, and that's equivalent of around 1 in 10 women and those assigned female at birth. So it's very likely you'll either know someone with endometriosis, perhaps within your family or perhaps somebody you work with, or you may even suffer from the condition yourself. The definition of endometriosis is endometriosis is defined as the presence of tissue like the lining of the womb, found elsewhere within the body, and this can be found in as far away places as the lung. But the commonest site for endometriosis is within the pelvis, and this slide here shows a section through the pelvis and outlines the three subtypes that we're aware of to date. And the commonest subtype is what we call peritoneal disease, which is disease that lies on the wall of the pelvis, and that accounts for around 80% of the disease that we see. We also are aware of deep disease. That's another subtype, and this type of disease is a sort of more nodular disease, which often involves the bowel and the bladder, and also can cause a lot of scarring. And then the disease that you see on the right is called ovarian disease, and this involves endometrioma or cysts within the ovaries. But of course, endometriosis isn't just about having lesions, disease within the body. It's about the multiple symptoms that it's associated with, and these can range from different types of pain symptoms, pain with the menstrual cycle, pain outside of the menstrual cycle, pain with sex, opening the bowels, passing urine. It's associated with difficulty getting pregnant, can be associated with excessive tiredness, can be associated with mood disorders such as depression, and a whole range of gastrointestinal and urinary symptoms. And I think one of the things that we are learning more and more about endometriosis is it's what we call a systemic disorder. It affects the whole of the body, sadly. And as well as the lesions and some of the symptoms I've described, it can be associated with other gynecological conditions such as fibroids and adenomyosis, and as I say, a whole range of different symptoms out with what we term the sort of reproductive tract. And it can even have an impact in later life, predisposing patients with the condition to heart disease and certain types of cancer. The problem with endometriosis is that we really don't know enough about it. There's been a long-standing belief that endometriosis, at least within the pelvis, is due to something called retrograde menstruation. So that's when tissue from during a period goes back up the fallopian tubes into the abdominal cavity. But we know that this happens in around 80% of people who menstruate. So why does this tissue form endometriosis lesions in some people and others? And why does the endometriosis cause so much pain and other symptoms? The other problem that we have with endometriosis is that there seems to be this diagnostic delay both in Scotland and in the UK and beyond of anything up to 7 to 8, 9 years. And this delay is accounted for by a number of things. First of all, we are aware that both the general public and even clinicians themselves have a poor awareness around the condition. So this can mean that the symptoms that a patient presents with can be normalised. But the second problem is that the symptoms of endometriosis can be shared by a number of other chronic pain conditions. I've just listed some of these on this figure here. You can see that there can be a crossover with irritable bowel syndrome, bladder pain syndrome, even some musculoskeletal symptoms. So this can mean that it's sometimes confused or difficult to diagnose. The other problem that we have is that there isn't a simple blood or urine test that can diagnose endometriosis. And the majority of patients have to be diagnosed by being given a general anaesthetic and going and having surgery, usually keyhole surgery, to make the diagnosis. But there are some what we call red flag symptoms and signs of the disease, and I've listed some of these here. Most of these symptoms are symptoms which have a cyclical pattern to them, so that should raise the alarm that there may be endometriosis present. And there are certain subtypes of endometriosis that can be diagnosed a bit more straightforwardly than having surgery. This shows a cyst that can be picked up on ultrasound, and some of the deep disease, the nodular disease, can be picked up on ultrasound or on MRI scans. Endometriosis is a complex disease, as you may have gathered, and so it therefore requires a multidisciplinary team to manage it. So this can include gynecologists, a colorectal surgeon, urologists, pain medicine, psychologists, physiotherapists, specialist nurses. So a whole range of different specialties to try and better manage the condition. And we are fortunate there have been standards of care guidelines published both in the UK in the form of the NICE guidance, which was published in 2017 as being updated this year, and then the European Ayrshire guideline, which was updated and republished in 2022. But broadly speaking, the treatment of options for endometriosis fall into surgery to remove the endometriosis and hormone treatments. And these hormone treatments have come about because we know that the disease itself is responsive to the hormone estrogen. With regard to surgical management, if we look at the three common subtypes, superficial disease can be managed by keyhole surgery, by either excising it or ablating it, and there's still a lot of debate as to which is the better treatment approach. Ovarian disease tends to be excised, and then the deeper disease, because of the complexity of the surgery required to remove this disease, is generally carried out in endometriosis specialist centres, which are accredited across the UK, and there are currently 3 in Scotland at the moment. The problem with surgery is it doesn't work for everyone, and even when it does work, there is quite a high recurrence of symptoms, anything up to 50% within 5 years, and we don't really fully understand why this is. It may be because new lesions develop, maybe because lesions are missed at the time of surgery, they're not visible, but it's probably because the endometriosis pain is complex and that surgery ignores the role of nerves and immune cells. This table lists the current hormone treatments for managing endometriosis pain, and they can be broadly broken down into combined contraceptives, which can be given by tablets, a patch or a ring, progestogens, which again can be given by tablets or an intramuscular injection, a coil or an implant. GnRH agonists, which put the body into a temporary menopause, which are usually given with HRT, and these can be given by subcutaneous or intramuscular injection. And then a new class of drugs which are about to come into the UK, which are called GnRH antagonists, which are quite similar to the agonists, except they can be given in tablet form, and there's some preparations that are coming as a tablet form with the HRT combined. The problem with hormone treatments is there isn't one that stands out above the other, so it's quite difficult as a clinician to recommend one particular treatment over another. They're not curative, they only work whilst a patient is taking them, and they all have different side effects. And of course these hormone treatments are contraceptive, and it may be that a patient with endometriosis doesn't want to take something that stops them getting pregnant. The other treatments available are other pain management strategies. Obviously they're not going to impact upon the disease itself, but they can be given sometimes in combination with surgery or in combination with hormone treatments. And you may recognise some of the drug treatments here. Some of these are analgesic antidepressants, some of these are analgesic anticonvulsants. I put in grey some of the opiates that are listed here, because obviously we're keen to try and avoid prescribing opiates if we can because of the risk of dependency, but they're often used for short courses for flares of endometriosis pain. The other approaches which again can be helpful in managing the pain, these aren't a cure or a treatment for the pain, are work with a clinical psychologist, and this can be helpful in terms of increasing education around pain mechanisms, helping with pacing, helping with relaxation, and things like mindfulness can sometimes be helpful. Similarly, good pelvic physiotherapy is helpful. If you're living with chronic pain for a long time, the pelvic floor muscles can become very tense, so the physiotherapist can help with postural exercises, breathing techniques, and even pelvic floor manual therapy, which I've listed here. We're also fortunate in Edinburgh to have access to an acupuncture therapist, which we also find helpful as an adjunct to managing the pain. And then just very briefly to finish, I did mention that endometriosis can impact upon fertility. So around a third of patients will have difficulty getting pregnant if they have endometriosis. The first thing to say is that hormone therapies aren't helpful for treating infertility, but surgery can be helpful, particularly for the superficial peritoneal subtype. But then the mainstay of treatment for patients who present with endometriosis infertility is generally IVF treatment, which is usually, fortunately, fairly successful in the majority of patients. So I'll just finish there and just say thank you for listening, and I'm happy to take questions.
Thank you so much, Andrew, for that. I'm just bringing myself back onto the screen. Yeah, thank you so much for that. I think that was a really great overview. And I mean, I learned a lot myself. And I think what really came across was the fact that, you know, it is a whole body condition, and also that it affects people in very different ways, and that the condition, you know, that it will present in very different ways. And so the treatment will be different. And I think, if anything, it just underlines again the importance of raising awareness and having that education around endometriosis, because, you know, like you say, that and in turn will help to support hopefully quicker and easier diagnosis potentially for people. So I think that was really, really helpful. There's a few questions coming in the chat, but I suppose just to use abuse the chair's position, I just have a wee question. You know, with all the work we're doing around kind of women's health and experience of a health that are kind of particular to women or you know, people who menstruate particularly, I think there's sometimes quite a lot of stigma attached to these conditions and experiences. And so I'm just wondering if, you know, because of stigma, I think you get a lot of myths and misinformation. And so from your perspective, is there one kind of particular myth around endometriosis that you think would be quite valuable to bust, if you like?
Yeah, there are a couple of things, I suppose, but the first thing is that endometriosis can affect anybody of any age. I think for a long time, healthcare professionals were taught that it was a disease of women in their 30s and 40s, and certainly that's commonly when we see patients, but of course it can present in adolescence, it can present even beyond the menopause, and we're learning more and more about endometriosis in these kind of different age categories with time as time moves on. So I think probably the first thing is, you know, always be aware that endometriosis can present at any time in the life course.
Thank you for that. I think on that point, there's a few questions, or kind of connected to that point. I'm just seeing a few questions in the chat that kind of relate a little bit to endometriosis happening, particularly maybe during or kind of at menopausal time. And I just wonder if you've got anything in particular, any kind of research that's ongoing, exploring that particular time period for people.
So it's a good question, and there isn't good research around that particular time point. So I think just to reiterate, the first thing is to say that people need to be aware that it can still occur during and beyond the menopause. Whilst it is thought to be a disease that responds to estrogen, and whilst in the majority of cases symptoms seem to get better, there are a proportion of people in whom the symptoms don't seem to go away. And sometimes people need to have further surgery. You know, we still find further disease after the menopause. Some people, we don't find disease, but they still have persisting symptoms, and then we have to work out the best way of managing the symptoms. And they're probably because of the endometriosis, and maybe even if they've had surgery, have somehow damaged the nerves within the pelvis, and we need to manage that side of things. There has been some research looking at a particular receptor in endometriosis following the menopause, and this was done quite some time ago, and this supports the use of something called an aromatase inhibitor, a drug that's given after the menopause, which some patients respond to. But I think the menopause side of things is complicated, and that's when it needs to be managed, at least in secondary, if not in a specialist centre, to get the best advice. But we definitely need to do more research in this area.
No, that's really helpful, because another kind of thought that I had was around, obviously there's a lot of progress, tons of progress that's kind of coming out at the moment, obviously linked very much to a kind of increased research onto endometriosis. So it's interesting to know that there's maybe that gap there, and there's exploring kind of more options. There's a question in the chat. You did speak about how in many cases diagnosis can be difficult because there's maybe different things going on, or it can kind of present similar to some other conditions. So, but someone has a question around autoimmune disorders, and just wondering if you could speak about the relationship between endometriosis and other autoimmune disorders, for example, rheumatoid arthritis or IBS.
Yeah, so it's a good question. So I think there's more and more research around endometriosis probably being an autoimmune disease, or at least being part of that group of diseases. So there is, if you have endometriosis, you are at slightly increased risk of rheumatoid arthritis. IBS is an interesting one, because I think all of the symptoms that people experience with IBS, often patients with endometriosis will experience as well. So they may have diarrhea, constipation, bloating. So they're often quite difficult to tease out. And we talked about in an article we wrote some time ago about whether actually the symptoms, IBS type symptoms, should just be incorporated as to part of the diagnosis of endometriosis. And I think it's one of these things that we need to, we're doing some work actually at the moment with a group in Denmark, where we're doing some sort of national questionnaire work to look at, to try and re-look at all the symptoms that people present with again. And it may be time that we actually sort of re-evaluate the diagnosis a bit better, and that might help with some of the problems with the crossover in diagnosing these other conditions.
No, that's really helpful. I think in some way, maybe particularly slightly related, just again into understanding, I suppose, maybe like, the relationship between endometriosis and the kind of gut. Is there research into diet and endometriosis and the kind of impact? Yeah,
I think this is something that's, sorry, I've just managed to see the questions. I've actually got COVID today, so my mind's a bit all over the place, so apologies.
No, I'm so sorry to hear that.
It's fine. I'm fine, but I've got
you're feeling bad.
Sorry. So we're in Edinburgh. We're actually doing quite a lot of research into diet. We've just completed a big international survey asking people to tell us about diets they've tried and whether they've had an impact upon pain, and that's been very interesting. We'll be publishing the results of that shortly. But we're also collecting samples of blood and of feces from patients with endometriosis to look at their microbiome, which I think lots of people have read about, which is basically the pattern of bacteria within the gut. And we know that that can be impacted upon by diet, and that can also be related to endometriosis. We're not the only people who are doing research into diet. There's research being done in many centres across the world now, and I think there's absolutely no doubt that it can impact upon symptoms. And I'm sure Vicky and Julie would agree with me on this. Whether it's actually causative, I think, is probably a different matter, and I think this is where ultimately I would like to see a dietitian more involved in the management of patients with endometriosis, because they might be able to help them, logically and remove various foodstuffs from their diet which might be causing flare-ups or having the worst impact upon their symptoms.
No, that's really helpful. there's lots of questions coming in the chat, so bear with me, people, as I kind of go through them. We might not be able to get to everybody's question, but we will do our best. I suppose there's one question, and Andrew, if there's a particular question that you would like to cover, then just let us know. But I know that, you know, you spoke a lot about, you know, it's a very multidisciplinary team, and you know, obviously trying to kind of cover all these different kind of impacts in people's life. And there's a question, you know, I know that you do work as well at EXPPECT on pelvic pain, and so, you know, somebody said there, what should happen if patients have pelvic pain, but either maybe they don't have endometriosis, or they might not want to go through the diagnostic process, because like you say, you know, it is obviously surgical to many degrees. So is there still options for people to access that kind of specialist support, or how would you recommend people, if they have a concern, what would you recommend the kind of process for them to kind of reach out and get support?
So it's a good question, and I think, I mean, we're fortunate in Edinburgh that we have got this service set up, which is, as you've just said, it's for patients with endometriosis with pelvic pain who either have tried lots of different treatments or want to access the sort of pain management approaches that I talked about. But there's also a big group of people who may have been through investigations for endometriosis and have the symptoms, but maybe don't have lesions identified at laparoscopy. And they also obviously need help. And again, this is where the pain management approach can be helpful. What I would say, the first instance is obviously to see your GP. If you're wanting to go more down the pain management route, and you know, say don't have access to a specialist pelvic pain service like we have in Lothian, there are chronic pain services, so you can be referred to a pain medicine specialist, and they should be able to give you access to the clinical psychology team, the physiotherapy team that are associated with the pain management around other conditions like fibromyalgia, like, you know, chronic back pain, all of these things. So there is a kind of way in, but I think it is a bit tricky to negotiate and get to it, I agree.
Perfect. I think that's really helpful. And you know, the Alliance, we produced a kind of a checklist if you want to go to your doctor with a particular maybe menstrual health concern, whether that be pain or heavy bleeding, so we can share that with people. We did that in relation to the Scottish Government's Women's Health Plan, so we can share that with people afterwards, and it just helps you to have that supportive conversation about what you're experiencing. And I'm conscious of time, and I'm keen to bring in Julie and Vicky to chat about their experiences, but I suppose I don't know if there's any particular question that's jumping out from your side of things, Andrew, that you think is something you'd like to cover?
There was one at the end about chronic UTI and the links with endometriosis, and I think this is a really good question, because a bit like the irritable bowel type symptoms, lots of patients with endometriosis present with urinary symptoms as well, and I think we're maybe not very good as clinicians at knowing how to manage these. This is where it's really important having the multidisciplinary team and bringing in the urologist's opinion to help. But I do think that this is an area that needs a lot more research going forward, and something that we're actively pursuing in Edinburgh.
That's great. Thank you so much. I'm going to kind of pause on the Q&A for the moment, because, as I say, we've got Vicky and Julie to speak about their experiences, and I think probably in relation, they'll maybe cover some points that you've popped in the chat anyway. But can I just say thank you so much, Andrew, for all that, especially knowing that you've got COVID. I hope you're not feeling too bad.
No, I'm fine, thank you, and thanks for your time. I'll hang on as well in case I can help with any questions.
That's brilliant. Thank you so much for that. So I'm just going to bring in, there we go, and Julie and Vicky. So lovely to have you both here. Thank you so much for taking the time. As we said at the start of the session, obviously this session's an opportunity as well to hear about people's direct experiences of having endometriosis, so that we can get a picture of, I suppose, the condition and how it can be very different for each person. And I think Andrew's presentation really kind of underlined that as well. So really pleased that you could both join us today. So just to kind of introduce you both, so Julie and Vicky both head up endometriosis support groups. Vicky Chapman runs the Dundee endometriosis peer support group, and Julie Burns runs the Ayrshire group, and those both fall under the kind of umbrella of Endometriosis UK's peer support network for Scotland. We were also meant to be joined today by Tail McCready, who set up and runs an independent group in the south of Scotland, but unfortunately Tail couldn't join us today, but I know that she had some great insights as well to make, again, that were very specific to her own experience of endo. So yeah, thank you so much, both of you. I think to begin, it would just be really great to hear briefly from each of you about your own kind of journeys with endometriosis, because I'm sure they've been quite unique to yourselves. And I suppose with that, maybe the impact that having endometriosis has had on your lives in kind of different or maybe similar ways. So maybe who's first on my screen? Julie, I don't know if you want to come in first, and then Vicky, if you want to jump in.
Yeah, great. Thank you, Jen. Yeah, as Jen says, hi, I'm Julie, and I volunteer with the National Endo UK charity, founding and running the Ayrshire support group. So just a bit about my own personal journey. It's been a long and hard journey. First kind of started when I was around 15 with heavy periods and having to take time off school during those crucial exam years. Like a lot of endo sufferers at that particular time, I was put on the contraceptive pill, and that kept my symptoms fairly manageable for around 10 years. The lack of awareness of endo in the medical community is a real challenge. I've got numerous examples of being gaslighted, like all the ladies can relate to. I was once told by my GP when I was 19 to have a couple of kids, and that would sort me out. So yeah, not the best experience. Fertility and having children was never on my life plan, but if it had been, maybe investigations would have discovered my endo at an earlier stage. So I'm just going to fast forward on 28 years to the age of 43, when I was finally diagnosed with stage 4 severe, deep infiltrating endo. It was on my ovaries, my ligaments, and all around my uterus. The uterus was distorted and retroverted, which was picked up during my first cervical smear at age 20, and is one of the most common red flags as well. But again, it was never recognised. My left ovary was stuck to the pelvic wall. I also had adenomyosis, which, as Professor Horne mentioned, is quite common for women to have both. So 28 years to diagnose a condition that's as common as asthma and diabetes. Yeah, so in terms of treatments, I've had them all. I've had various hormonal medications. I've had a surgical ablation, which burned off the lining of the womb. I've had chemical menopause with decapeptyl injections for 2 years, had my ovaries removed. I've had a total hysterectomy, 4 surgeries in a total of 11 years. And based on the NICE guidelines, which we talked about earlier, I should have been referred straight away to an endo specialist centre, but my own GP didn't even know that centre exists. So what hope is there for others? For me at the moment, I'm well. I'm very well. I have been for a couple of years. So I'm now channeling my frustration and previous anger into raising as much awareness as I can, just so that other younger women don't have to go through similar journeys. That's my goal at the minute. I'm 51, have been on either chemical or surgical menopause for 13 years, but that's a whole other can of worms, which I'll leave for another time. So for me, forming the support group has really helped. There was never a group in Ayrshire when I was going through my journey, and I spent a lot of time in Dumfries and Galloway, and I know that Teo has the group set up now, but 28 years ago it was never available. So that's what makes me tick. I want to expand the group, bang the drum. make sure sufferers have up-to-date information and peer support of each another. I'm also working with the charity to champion the endometriosis friendly employer scheme. I've managed to lobby NHS Ayrshire and Arran, East Ayrshire Council and South Ayrshire Council. And just last week, myself and the Scottish Development Coordinator for the charity met with other HR representatives from all of the West Scotland Scottish Health Boards to try and encourage them to sign up. I was thankful that my own employers at Glasgow Caledonian University have signed up. So I am also an endometriosis champion in my workplace, and I'm currently supporting around 10 members of staff and hosting a student event this week as well. The only positive thing to come out of this journey is being connected to this amazing community of strong women. They all just want a better pathway and better management. So that's really my end goal, and whatever I can do to help that, I'm banging the drum. Thank you.
Well, thank you very much, Julie. I know that a lot of people will be very appreciative of you banging the drum. And thank you as well for sharing your own experience, because, you know, it takes a lot of energy to constantly kind of relive these things, and so really appreciate you taking the time. Vicky, if you'd like to come in.
Hi everyone. So as Jen mentioned, I'm Vicky Chapman, support group leader for the Endometriosis UK Dundee support group. So my journey with endometriosis started when I started my periods when I was aged 11. I always had really heavy, bad clots and going through a ridiculous amount of period products every week. My periods lasted for a week all the time as well. It was always Monday to Sunday, which I thought everyone's was, and obviously quickly found out that wasn't the case. But in terms of like my journey with endo, so like I said, I always had bad periods and I needed to take time off school, but I thought it was normal. My mum had always had bad periods, so I just assumed it was just part of who I was, part of being a woman, and that was that. I went to the GP when I was in my teenage years and I got put on a drug called mefenamic acid, which I'm sure many of you will be familiar with. It didn't really do much, if I'm honest. I didn't really know what it was supposed to do, you know, teenage girl on medication, didn't really know. I then was put on the combined pill when I started going out with my now husband. And that was like my choice in terms of a contraceptive. And my periods generally just got worse and worse. And I started getting constipation as a side effect of my contraception. Went to the doctor, got put on a different pill, and then got told, oh, you know, my skin started breaking out. That was the next thing. So they put me back on the pill that caused constipation. So I had a few years going backwards and forwards with different pills. And then I got put on the mini pill and my period stopped. And my quality of life improved when my period stopped, but I hadn't put two and two together at that point. So that was a few years ago. I then at some point went back onto a combined pill again, and again had the same issues, back onto the mini pill again. And I ended up being admitted to hospital in 2015 with suspected appendicitis. So no scans done, just got taken in for emergency surgery, came out and they said, oh, your appendix was fine, but we've removed it anyway. So it turned out after that, I found out that I had remnants of a burst cyst. So I made the decision to come off the pill, which I did. And for about a year and a half, things were fine. My periods came back, but they were very irregular. So whereas they'd been very regular before, suddenly became very irregular. And it wasn't until March 2017 when I started getting pain on a daily basis. I had lower back pain, I had pelvic pain. I was just generally feeling really fatigued all the time. And I seen a few different GPs who were like, what's a UTI? Or it's been, so UTI or, you know, STD, whatever, that they thought there was something else going on. So I seen a GP finally who had asked if I'd had my cancer markers checked, and that was how my endo journey began. My cancer markers were high. I got told the next day my results were high, but a doctor couldn't speak to me for 24 hours. So I had 24 hours going, I might have cancer. Spoke to the GP and she said, oh, it might not be cancer, it might be something else, but I got seen very quickly by getting in. I don't take that for granted how lucky I am that I did get that treatment. So I had scans done and they showed up cysts, and basically went round for a wee while, going to see gynae, having more scans, had an MRI scan in June 2017. And I got told that I would hear very soon what the results were, but the rush stopped. So they thought it was suspected cancer potentially. I now have my medical file, which had suspected cancer written over it several times over, but that wasn't kind of being relayed to me in so much kind of gusto as what it was on my medical notes. And I then got told I had suspected endometriosis and I needed to see a specialist, and that was kind of where it was left. So I started to lose a lot of weight. I lost about 1.5 stone in weight, couldn't eat a full meal anymore. I was down to about 7 stone. I'm quite small anyway. So it was a lot of kind of trying to work out what was going on with my body. I felt like it was failing me a lot of the time. And then I had my diagnosis in October 2017, where I was told stage 4 endometriosis, my womb and bowel are fused together. I got told my pouch of Douglas was obliterated, was the word that was used. I got told I needed to go into chemical menopause, and my gynecologist came at me with an injection ready to go. And I said no, because I didn't know what it was going to do to my body. And we had a period of time where he was going, it's your only option. You'll end up with a colostomy bag if you don't go on this treatment. And it just went round in circles for a wee bit. So I took some time, researched myself, and then came to terms with going on chemical menopause age 29. And then went to my follow-up appointment. They told me I could try the pill, or I could try the coil, or I could try this, or I could try that. And I thought, if I'd listened to him 6 weeks ago, I could have been sitting in chemical menopause already, thinking this was my only option. So I ended up, I went on the combined pill again for a period of time. Christmas 2017 was really bad. My pain was bad. My bleeding was just ridiculous. I was so fatigued. I had no energy. And then between Christmas and New Year that year, I ended up going on Zoladex to put me into chemical menopause. I wasn't offered HRT with that, but I was in chemical menopause for 6 months. And then since then, I've been on the mini pill. So June 2018, went on the mini pill, been on that since. I did start getting my symptoms came back again during the pandemic. So I went back on the surgery waiting list thinking, right, I need to get on this list and be seen. So that was October 2020, I got added to the list, and I had surgery in October 2022. And I had excision surgery of rectovaginal endometriosis and of my endometriomas. So chocolate cysts, like Professor Horne mentioned earlier. And since then, my pain has been better. I'm not going to say I'm pain-free, but I'm grateful for the days when I have less pain and I'm able to manage it better than I've ever been able to manage it before. But I'm not completely naive either. I know plenty of women who have gone through surgeries, had pain-free time, and then get to the point where they're back on the surgery waiting list again. So I suppose for now, that's where I'm at in terms of my personal journey. But during that time, I have also set up the Dundee support group. So that's now 4 years old. And I suppose to start with, I did it because there was only 3 groups in Scotland, Edinburgh, Glasgow and Fife. And I used to attend the Fife group. I travelled a 100-mile round trip to go and be in a room with women who understood what it was like living with this condition and how isolating it can be. And I suppose I wanted to do a bit of that myself, and I wanted to be like, right, let's offer someone a safe space. And it doesn't matter if you come to group meetings or if you're a lurker in the Facebook group and you want to just kind of check in and see what's going on in there. I think it's knowing that there's someone that at the end of a message there if you need it, or, you know, someone who you can say, I have this symptom, does anyone else have it? And you're like, oh, actually, yeah, I do have that. Like shooty bum pain is a big favourite in the Dundee group. It's a favourite term that's been used. And I think it is just about building up those friendships and that peer support. And that for me is one of the key things I've taken away from being diagnosed with endo. Yes, it took me 18 years to get there. And now I'm playing my part in helping other people get their diagnoses and helping them feel less alone in that journey. So yeah, that's my story.
Thank you so much, Vicky. And again, thank you for sharing your story, because it's not easy. And I see people in the chat just kind of reiterating that and really appreciating you both sharing that. I mean, I think it's coming across quite clearly from your experiences that, you know, And like Professor Horne was saying, you know, that diagnosis process, we're trying to shrink that is really important for people. And I think, you know, having that education around endometriosis, but just menstrual health as well, because like for both of you, it really started with, you know, your periods and really heavy or kind of maybe abnormal pain or bleeding. So it's all of us having a better awareness of that kind of normal versus maybe not normal is really important, so that we can all kind of get the support when we need it. You both spoke about that real the kind of dance with trying different treatment options and finding something that works for you, and finding something as well that suits your personal, I suppose, objectives, if you like, because like you say, people will have different kind of desired outcomes, whether that be, you know, fertility based or pain management. So I know that you have all tried different things, but I'm wondering from a kind of self-management perspective, if there's things that have been particularly helpful. And I'm quite curious as well, you've both spoken about the power of peer support for supporting your mental health and kind of emotional health. But I think, you know, it's came quite clearly that this whole process can be really taxing emotionally and mentally, as well as really tiring, like that fatigue as well. So yeah, I suppose self-management, if you've got any kind of things that have worked well, but particularly maybe things that have helped you kind of mentally or emotionally, and feel free to jump in.
Do you want me to go first, Julie? Okay, so for me, I know a lot of people will say this helps them as well, but a hot bath, like the amount of time I spent in a hot bath or with a hot water bottle attached to it, or the, you know, adhesive heat pads you can get now. There's lots of different things that can help. Heat therapy is a big thing that helps me. I also like going for massages as well when I can put time in to do that alongside volunteering and working full time. But it's something that is self-care for me as well. I'm trying to get better at building in time for self-care, because I think I don't think I'm speaking alone here in terms of volunteering, but a lot of us put a lot of time and energy into our support groups. And I think sometimes we maybe don't put that support and energy into ourselves. And I think that's a really key part, because we can't pour from an empty cup. So trying to give ourselves more time as well. One tip I would just share as well, that I would share with anyone who's going through a diagnosis journey, is to keep a pain and symptoms diary as well. So the My Symjo, which is a symptom journal created by someone who lives with endometriosis, is a really useful resource. And Endo UK also have a template on their website, but being able to arm yourself with that information ahead of appointments can be really helpful. And along with that, preparing for your appointments and thinking about what you want to get out of those can be really beneficial too.
Yeah, just for me, the same as Vicky, the heat pads were a godsend, particularly when you're trying to do, you know, a day's work, and a lot of people are on their feet, and I'm office-based roles, so it's easier, and the working from home in the last couple of years has certainly helped that as well. But for me, exercise has always been quite important. I find if I stop, the pain would return. So not only does it help me, I like to run. I'm not fast, I'm not winning any marathons at all, but I don't go far. But, you know, a 5K a couple of times a week out in the fresh air, it just clears your head. As Vicky says, it's quite a lot to take on other people's frustrations too. And as a leader, you do a lot of that. And I wouldn't have it any other way, don't get me wrong, but I'm older now, so I'm ready to kind of help. But 25 years ago, you know, you're a young lady with, you know, worried about taking contraceptives because your dad has a history of blood clots, so you can't take that forever. So yeah, for me, the self-care that Vicky mentioned is something I'm not good at, but I have been a bit more aware of that, certainly with the support of the other group leaders and other endo warriors across the country. So yeah, exercise and just looking after yourself is important.
No, that's both been really helpful, just to get a taster, I suppose, of what's worked well for you personally. And I can see some people in the chat are putting in some things that have worked for them. And I think the point you made as well, Vicky, on keeping a pain and symptoms diary, is really helpful. And like you say, having that at hand when you're speaking to a kind of medical professional is always helpful. So yeah, I'm very conscious of time. This is such a quick session, but I suppose just to close us off before we kind of close the session, I wonder, obviously, this month's Endometriosis Awareness Month, or Action Month, and there's lots been happening across the month, and that's obviously been kind of led by Endometriosis UK. And so you've spoken a lot about the things that you do to support yourself, and I just wonder, to finish, if there's a kind of brief kind of a call to action, if you like, that you might have about what maybe other people can do to help support or kind of better understand experiences of people with endometriosis. And again, just feel to jump in.
Okay. I think one of my main things is to ask. So don't be afraid to ask us how we are. Don't be afraid to be that ally, I think, and just kind of give us a safe space to vent to cry with, to share with. I count myself really lucky that my parents are incredibly supportive, but I know not everyone has that. And yeah, I think that's my main point in terms of that. But from a government point of view, or from an NHS point of view, you know, communicating with your patients to say, yes, you're on the list, and you know, this is the likely waiting time you're going to have, or at least just an update on, we know you're still waiting, would make a huge difference. Because I think a lot of us just think that we're on the waiting list, and then it turns out that myself, I lost, my referral got lost, and so I lost quite a period of time because of that. So I think something from the NHS boards to say, you know, they know that we're there and we're not being forgotten about, I think would be really, really helpful. From a government point of view, I think seeing some action on the Women's Health Plan, that's not to say it hasn't come, but I think there's still more work to be done. And I think, you know, if the volunteer group leaders can get involved in that in any way, I'm sure all of us would be more than happy to do so.
Thank you, Vicky. And Julie, I know you'd previously mentioned employers as well.
Yeah, anyone who works for an organisation that may be interested in joining the scheme, it just shows your staff that you care about them, and that you're giving them those, you know, opportunities for modifications to work from home, etc. And anyone who's interested, get in touch with Jen, and she can pass on my details. I'm very happy to help anyone. In Ayrshire, we've got a lighting up of a viaduct in Kilmarnock on Wednesday evening for the end of Endometriosis Action Month, and we've also got another local businesswoman who is herself a sufferer, and she's lighting up her building, the Halo, which is near Ayrshire College, and we've got a little walk as a group on Wednesday evening. So plenty of information on all the support group Facebook pages and the Endo UK website on how you can get involved. And yeah, just as Vicky says, just ask, just please don't be alone. It's a lonely enough condition to have to deal with. And I've been, like Vicky, fortunate in my family. My 75-year-old parents are sharing all of my posts, you know, even my dad, which is not something that would have happened a few years ago. And I've got a really supportive husband and family too, so that helps. Yeah, so please just ask anything at all.
Thank you so much, Julie. We have came to time, so I've just brought Professor Horne back on the screen, just to say thank you so much to everybody for taking the time to come along today. I think we've covered a lot from obviously a clinical side with yourself, Andrew, and then Vicky and Julie sharing from your experiences. So I really appreciate you coming along, and thank you very much. Thank you as well to Linda for interpreting for us today, and Claire as well for capturing everything in the graphic, which is coming along nicely. And as I say, we'll share that with everybody after today's session. There's lots of places where you can get further information on endometriosis, and I would encourage you to do so, because I know that we didn't cover maybe everything in the chat and in the Q&A, but we covered, I think, quite a lot. But NHS Inform's Women's Health platform has great resources on endometriosis, including some great videos, so check those out. Also, the EXPPECT Centre, which Professor Horne obviously works within, they have lots of information about ongoing research into endometriosis. Endometriosis UK, the leading charity for endometriosis, has lots on their website, and obviously that's where you can learn about maybe a peer support group near you if you yourself have endometriosis. And then, as Vicky mentioned, the Women's Health Plan has a number of actions related to endometriosis, and there has been some, progress being made on those actions. So there's a first year progress report available online for the Women's Health Plan, so you can see what's been happening around endometriosis and kind of see what's the kind of next focus as well. And then finally, at the Health and Social Care Alliance, we are running a kind of varied programme of work on the kind of priority areas in the Women's Health Plan, with endometriosis obviously being one of them. So if you're interested to learn more about what we are doing, including kind of more events like this and different types of information, then you can sign up to our mailing list.
For more information, see the links in the description box.